Good evening, everyone, and welcome to our weekly Thursday CME. The topic for today's CME is Immunotherapy, a roadmap to childhood cancer. The chairperson for today's CME is Dr. BP Choudhary. Sir is senior consultant, hematology and hemato-oncology. Presently, sir is going at two centers in Delhi. One is Batra Hospital at Tughlakabad, and other is PSRI Hospital at Secy. Sir was director professor of hematology department at AIMS. Sir was the founder of hematology department at AIMS. Many publications and many books sir have written. The two books which is worth mentioning are, one is Advance in Hematology, Volume 1 and 2, and second is Thalassemia Care and Control. Currently, sir is also a medical advisor for National Thalassemia Welfare Society and medical advisor for Federation of Indian Thalassemics. Sir, over to Sir Dr. BP Choudhary. Sir, yes, start, sir. Sir.
Sir is on mute. Sir may be on mute.
He's on mute. Sir is on mute.
No. Am I
yes,
audible
sir.
now?
Yes, sir.
Yes, sir. Now you are audible.
Okay. I think first, right at the outset, I convey my heartfelt thanks to Dr. Sandhya and Dr. Bimal for inviting me to chair this session. And I think the topic which has been chosen has been very appropriate, as on the 15th of this month, just 3 days back, we had International Childhood Cancer Day. And today we are talking on a very, very important topic on childhood cancer. I think one thing is very clear. Many times we follow what adult medicine has done, but it is in the cancer therapy. It is the childhood which took a lead, particularly at St. Jude's Children's Hospital. The innovation of the combination therapy and cyclical therapy, which led to the cure of every child. When I was a student, it was said that if you diagnose a child with cancer, you are literally certifying a death. Of course, you are not putting the dates. But today, the era has changed, and today we talk, every child with cancer is curable. And our target is that we must ensure that their child lives forever. Because it has been the result of various therapies. And then, of course, that molecular targeted therapies, which has come in the near future, has come in the recent past, immunotherapy and so on, which has helped us to offer complete cure in large number of childhood cancers. And the adult physicians or the hematologists have now followed the same principles what has been really initiated by the pediatric group. And today we are in the era that where we can cure every child. And today we are going to talk, have a discussion on the newer drug and immunotherapy in childhood leukemias and lymphomas. And the person who is going to talk is very dear to me, Dr. Gauri Kapoor. She was the one who initially got training at Tata Memorial Hospital. And then she had at the St. Jude's Children's Research Hospital training there. And she was the first pediatrician who started total commitment for hemato-oncology at Rajiv Gandhi Center in Delhi, and has been working there since the inception of Rajiv Gandhi Cancer Hospital. And currently, of course, she's the medical director in the RG Cancer Center. Her prime areas of interest has been in the pediatric hemato-oncology, molecular oncology, stem cell transplant, and of course, all this is possible when you are totally committed to increase the awareness of the cancer in the community and its prevention. For her work, she has been the recipient of Heinz Fellowship from Royal College of Pediatricians. She is very well trained and has trained many people.
I think we lost the sound.
Lost the sound. हाँ पापा पापा टीवी तो बंद कर
Doctor will.
Dr. Choudhary, we can't hear you.
Sir, you are not audible. Your video also is not. Sir,
Can you hear now?
Yes, sir. Now,
Yeah, now we can hear.
your audio also is there.
Well, I didn't change. If you want, I'll reintroduce. I hope. Anyway, I'll start again from the beginning in that case. That today we are meeting on a childhood cancers. In fact, about 3 days back, that is on 15th Feb, is the International Childhood Cancer Day. It is basically being done to achieve what the cancer cure we have achieved and to see that how we could go ahead further in improving the cures in childhood cancer. The childhood cancers were the first to start with the principles of combination chemotherapy, cyclical therapies, and which led us to improving the cure rates in various childhood cancers. And this was as a result of development in the combination therapies and cyclical therapies, molecular diagnosis, and then, of course, the target-based therapies and development of immunotherapy for these children. Today we talk of that every child with cancer is curable. And today we are on the eve or just post after the eve of the International Childhood Cancer Day. We have a very learned speaker, Dr. Gauri Kapoor, who is going to talk to us on new drugs and immunotherapy in childhood leukemias and lymphoma. Dr. Gauri Kapoor has been very close friend of mine, close associate. She was the first one to join as a Rajiv Gandhi Cancer Hospital as a pediatric oncologist after her training from the Tata Memorial Hospital and at St. Jude's Children's Research Hospital from USA. And currently she is the medical director at Rajiv Gandhi Cancer. Her area of interest include pediatric hemato-oncology, molecular oncology, stem cell transplant. And of course, when you achieve such a result, you have to ensure that we are increasing the awareness in the community, in the general public for the early diagnosis of cancers. And she's going to talk to us, and I don't want to be in between her and my fellow pediatricians, and I hand over the mic. I request Dr. Gauri Kapoor to talk to us on new drugs and immunotherapy in childhood leukemias and lymphoma. And if time permits, she may cover cord blood cryopreservation, hope or hype. Dr. Gauri Kapoor, over to you. Dr. Gauri.
Thank you. Thank you, Dr. VP Choudhary, for your very kind and generous introduction. These words mean a lot to me coming from you. At the outset, I would also like to thank Dr. Bimal Kumar and Dr. Sandhya for giving me the opportunity to present this talk at the South Delhi IIP Pediatric Study Group platform. It's a great privilege to be able to share this platform with you, especially as Dr. Choudhary mentioned that, that on this week itself, it was International Childhood Cancer Day, February the 15th, on which day we want to increase awareness. And we want to actually, the aim of this theme was together we can improve outcome for childhood cancer. So in that way, the pediatricians and the pediatric oncologists and hematologists together can come together to increase the awareness and improve the outcome. With that, I come to my talk on immunotherapy in childhood cancer, a roadmap. And as Dr. Choudhary has very well mentioned, childhood cancer has achieved cure rates of up to 80% in the Western world. And now the focus therefore has shifted. How can we save those children with relapse? And how can we make this treatment less toxic to the children, because they are going to survive, and when they survive, they should have good quality of life. So the immune system, as you know very well, has evolved in order to detect and eliminate pathogens that may harm us. They may protect us against infections or other diseases. Therefore, it serves as a watchdog and even protects us from transformed cells, which may lead to cancer. And we call this immune surveillance. This is a really exciting field in oncology today, especially in pediatric oncology. And over the years, one of the most exciting and yet enigmatic concepts in the development of cancer treatment is the implication that the immune system, our own immune system, can be harnessed and directed into a precision attack against a neoplasm. Immunotherapy is actually a very broad term and includes all drugs, techniques, and others which lead to immune-mediated control of cancer. As early as 2013, the front cover of Science had this, which said the breakthrough of the year, cancer immunotherapy, and how they harness T cells to attack cancer. So as you well know, what is cancer? It is the uninterrupted growth or proliferation of cells, and the tumor cells have antigens on their surface that would, if they triggered the immune system, cause eradication of disease. These are actually recognized as foreign by our T cells and by our NK cells. But if for some reason they are unable to, our own T cells are unable to recognize them, they do not get eliminated. And one of the theories of cancer is failure of immune surveillance. So actually, what is this immunosurveillance? It is a monitoring process of the immune system of our body that protects it and destroys any foreign cells, which could be cancer, which could be infection. So there are two actually processes going on. One is the anti-tumor immunity, which protects the body from cancer. And most of these are the cytotoxic T lymphocytes, NK cells, the dendritic cells, etc., and certain cytokines like interferons, interleukins, etc. On the other hand, we have this intra-tumor immunosuppression, which means the tumor microenvironment is producing things which is lowering this anti-tumor immunity. So they are in a balance. And if we see this balance, it is something called cancer immunoediting. So if in this balance, the anti-tumor immunity is good, we eliminate the tumor. That means cancer immune surveillance is working. But if the tumor cells emerge, that means the immunosuppression caused by the tumor is succeeding in suppressing the immunity of the host, that is us. So if we look at it pictorially over here, I will show you the top is the escape. So there are these pre-malignant cells and they become tumor and metastasize when the tumor microenvironment produces immunosuppressive cytokines, which do not allow our own T cells to recognize them. So there is something called immunoescape. While if it is a normal condition where the body's NK cells and T cells recognize the pre-malignant lesion, they will be removed and the body will go on without the cancer. So this is what is immuno-oncology. So we have harnessed this knowledge. And now what is immuno-oncology? It is a form of cancer treatment that uses the power of our own body's immune system to prevent, control, and eliminate cancer. And actually it is used synergistically with other treatment modalities and approaches, which could trigger tumor cell deaths. They could alter the microenvironment, reduce the tolerance mechanisms, and stimulate immune responses, all of which may act in concert. And in the body, the major players are the cytotoxic T cells and NK cells, which have a protective role. And these are the various, the effector B cells, the effector T cells, and the regulatory cells, the plasma cells, all of which work together to inhibit tumor growth. So there are various types of immunotherapy coming to today's topic. The monoclonal antibodies. So there are lots, but we will focus on a few because they are more relevant to pediatric cancers. So then there are these monoclonal antibodies. Most of us are familiar with these. Then there are these very exciting CAR T cells, which are talk of the town today, the tumor vaccines, and the checkpoint inhibitors. I shall be basically focusing on these four. So these are the four we will talk about at some length. Coming to the monoclonal antibody. As you well know, these are prepared in the lab. These are engineered. They are genetically engineered. So how does it work? So supposing we look at this cancer cell, as you well know, the cancer has proteins on its surface called antigens, and there may be specific proteins on specific types or subtypes of cancer. And what happens is in the lab, so we recognize these antigens after studying their genetic, the antigenicity, produce antibodies against these antigens, and these antigens then destroy the cancer. Can you hear me? So how do they destroy? They may destroy either directly by attacking the cancer cell. They may trigger the destruction of the cell membrane. They may block immune system inhibitors. They may deliver radiation. So these monoclonals can also be tagged to radioisotopes that would specifically go to that particular cancer and destroy it and not damage the rest of the cells. Then they may even be bound to T cells, cytotoxic T cells. And we will see how those are. They are called bifunctional antibodies. And today, these are being used for non-Hodgkin's and Hodgkin's lymphomas, certain leukemias, and also for neuroblastoma. So they have come out of phase 1, phase 2 trials. Some of them are in routine clinical practice, while some are in phase 3 trials. So rituximab, I think many of you would have heard of rituximab, probably all of you. It is used for many benign conditions as well. So what is CD20? CD20 is an antigen which is expressed on all B lymphocytes in the body, whether they are malignant or even benign B lymphocytes. So rituximab is a pan-B cell antibody. And in the malignant diseases, the most commonly, although these 5 diseases all have B cells on their surface, on the cancer cells, but they have been very successfully used in Burkitt's lymphoma, which is a very high-grade lymphoma, and diffuse large cell B lymphomas, both of which it is now, for both of which it is standard of care. So I will show you this, share this article with you, published in New England Journal of Medicine in 2020, where they have used rituximab for high risk. So I may tell you that NHL in pediatrics has cure rates 80 to 90%. So whenever we introduce a new drug, we have to be very careful that it actually will not lower the survival. So for the high-risk mature B-cell lymphomas, it was tried. And basically, if you see, it has prolonged the survival in these children and adolescents who had high-grade mature B-cell lymphoma. So this is the graph, and I'll show you the data. 328 children, they were randomized, and all children were less than 18, all had high-risk BNH. It was not tried in intermediate and low risk. And this is the graph of event-free survival. This is of overall, and in both you can see there is almost a 10% better survival in those patients treated with rituximab plus chemotherapy versus those who received chemo alone. So about 10% improvement in this group, which is excellent because it anyway had such a good survival, and it is statistically significant. Now the current trials are trying two new things. One is, can we reduce chemotherapy in those getting rituximab for high grade? And for the low grade also now, can we use rituximab and further reduce the number of cycles and intensity of chemotherapy, thereby reducing toxicity? So moving on, there are other monoclonals as well, but I will not I'm trying to just give you an overview of the topic. So now this is a blinatumomab, very exciting new drug being used in India, although not available in the commercially in India yet. What is blina or BITE? It is a bifunctional monoclonal. So it's also called bispecific T-cell engager. So I'll show you this cartoon here, this thing in the middle. So it has this diamond shape here, which is an antibody, which is anti-CD19. What is CD19? CD19 is an antigen which is present in most precursor B acute lymphoblastic leukemia patients. And on the other side, this blinatumomab has an antibody which goes and locks onto the CD3 receptor of the T cell. So it targets these two, against CD19 from the leukemic blast and CD3 from our own body's T cell CD3 receptor, and it brings them together. So what does it do then? So you can see here, an immunological synapse is formed between the cytotoxic T cell and the blast cell with the help of this blinatumomab. So it has two antigens or antibodies on it. And what does this do? It then so the T cell therefore causes lysis or apoptosis of the blast cell, right? Not only that, but this also, it increases TNF alpha and the granulozymes and causes further T cell proliferation and serial lysis of the leukemic blasts. It is not available in India, but it has got excellent response rates. It's being tried. It has been tried successfully in relapsed B ALL, which have CD19 on their surface. It is not a standalone therapy, but it is a bridge to bone marrow transplant. So it was approved to treat adults and children with relapse who achieved remission, but still have minimal residual disease. And it has improved the survival by about 15%. You can see here. Refractory relapsed ALL is actually the third or fourth commonest disease in childhood oncology. So it is an important area where an improvement in survival will make outcome much better for childhood cancer. So you see, So the study was stopped early because of the excellent response to blinatumomab. It is approved for children and adults in the US. It is not yet available in India, but we hope that in the near future, it will be available. It has to be imported. Inotuzumab is another monoclonal antibody for ALL. It is an anti-CD22. It is also potent, but again, the effect is short-lived. Each of these have their own specific side effects. We will talk about those as well. I'll show you another monoclonal antibody. This is against solid tumors. So not only leukemia, lymphoma, but also solid tumors now are being used, are successfully being treated with monoclonals. As you may know, stage 4 in India, most patients will come with us with stage 4 disease. And their survival is dismal 0 to 20%. So we give them chemotherapy, surgery, radiation, autologous transplant. Despite that, the survival is not better than 40%. But now here comes this monoclonal prepared in the lab called dinutuximab. It is against a membrane glycolipid disialoganglioside. It is, again, it's a soft target for immunotargeting, and it has shown improved survival in the stage 4 disease. And you can see here that the 5-year overall survival, this is a short follow-up, therefore you may see the numbers look very good. 73% survival for stage 4 is like unthinkable. This is a children's oncology group study, and it has shown it's very promising. Again, not available in India, very expensive, cannot be imported, but I hope in the times to come, we will be able to get it. Like all other drugs, probably somebody will make in India. The limitations of all of these are that they are not standalone drugs. The remissions are short. The tumor escapes by finding some other antigen and some other escape route. Some of the side effects are cytokine release syndrome. So we have to be familiar with it before we use it, or it can cause, it can even be fatal. Then there are unique ones like infections, neurotoxicity, tumor lysis, VOD, etc., which is unique to each of these, specifically to separate ones for separate monoclonals. Again, as I mentioned, in leukemia and lymphoma relapsed, it's a bridge to transplant. That means we get the patient in remission and then we can take them to transplant, because otherwise if we cannot take frank relapse patients for transplant because of very high toxicity and death rate. Cost and availability. They are two big limiting factors, but we are very excited about these drugs because we hope that in the future, they will be available to us at affordable prices. So this is just a list of the various side effects that can occur with these monoclonals. So moving on to cellular therapies. In this, the most exciting is this CARS. What is CARS? Chimeric antigen receptor therapy, in which we take the patient's white cells, we genetically engineer the T cells and return them to the patient. So I want to show you this graph. So this diagram here, this big blue is the T cell, and this is a tumor cell. On the T cell, there is a receptor. This is called T cell receptor. The T cell receptor also has here this variable part. This variable part recognizes or does not recognize the tumor antigen. So what we do is, knowing which antigen is present on the cancer cell, for example, CD19, it could be a CD19 CAR or a CD22 CAR, whatever. And what we do, we take out the cells, select the T lymphocytes, and modify this receptor, and then give them back to the patient. And we call them armed tumors. So direct infusion of these armed tumors targeting T cells will bypass the barriers and the kinetics of active immune. So it will help us to overcome. So I will show you a better diagram to try to tell you how it works. So just a cartoon, it is very specific to the particular cancer. It's not a pan-cancer drug. It has a specific destination and it will only work very specifically. So I think I told you about this. They have been, now they are in clinical trials in the US. It is FDA approved. So these super soldiers have been produced for CAR T, right? And they are being used for relapsed B-cell leukemia, but not yet for the solid tumors. So I'll just show you what happens. So if the patient has got leukemia, we take the blood from this patient. We actually take white cells. From the white cells, we isolate or select only the T cells. Then these T cells, like I showed you in the previous graph, the T cells receptor will get modified so that it can recognize that antigen. Supposing it's a CD19 CAR, so we will modify the receptor so that it can recognize CD19 antigen. Then it will be ex vivo expanded. So the cells will be increased in size and we will give it back to the patient with certain conditions. And then we believe these T cells will recognize and kill the cancer cells. And how we give back, of course, you can understand that we will need a viral vector and all of those others. So it's a pretty complex process. But this is simply to tell you the principle of how it works, the T cell. And then I may tell you that these CAR T cells, they have also got a short-lived effect. So the various generation of CAR T cells are there, first, second, third, and fourth. And basically the idea is to make sure that the memory of the T cells does not disappear. That is the biggest limitation of the CAR T cells. They also, as you see here, this is a survival curve. And the survival curve for relapsed B-ALL that are either CD19 or 20 positive. So it can be an anti-CD19 CAR or an anti-CD20 CAR or a combination of anti-CD19 and 20 CAR. So you see here that when we give induction, so all of these treatments we prefer to use once the patient is in remission. And then we have something called MRD, that is a minimal residual disease, which detects disease as low as 1 in 1,000 or 1 in 10,000. And if MRD was negative, these CARs permitted the patient to have like you can see about 30–40% survival. And you can see here, chemotherapy either had no response in survival. You can see here, very bad outcome. So for the relapsed refractory, this is a boon, but it does have side effects, which we have to learn to reduce by the 4th generation CAR T cells. These 4th generation CAR T cells, also called T cell redirected for antigen unrestricted cytokine initiated killing, are called TRUCs. So basic idea is we should alleviate the systemic side effects of the CAR, and we should also give it long lasting memory so the patient may be cured and don't require transplant or any other treatment. So this is about the 2 very exciting, very happening immunotherapy strategies which are being used and are the talk of the town in the Western countries. And we hope, right now we don't have successful CAR in India, but hopefully. So CAR is specific to the patient. We cannot buy it off the shelf. While the monoclonals can be bought off the shelf like any chemotherapy drug, the CAR has to be engineered to that patient. So that is a limiting factor. Now we have what are called these checkpoint inhibitors. So what are these checkpoint inhibitors? Actually, these act as brakes and gas pedals of the immune system. So I may show you this little diagram here. And you can see this is a T cell. And this is here, the red one is the T cell and this purple one is the tumor cell. So the tumor cell is very smart. It produces a PDL1 ligand. PDL stands for programmed cell death. Normally, the T cell would be in the on position. It would recognize the tumor cell and destroy it. But the tumor cell produces this ligand, which goes and binds to the programmed cell death receptor on the T cell and switches it off, right? And therefore, if we can find something to block this, then that would be the checkpoint inhibitor. So this is what it is. So checkpoint inhibitor, nivolumab. So this is being used a lot in adults. And as you know, all new drugs first are tried in adults, then if successful, then their pharmacokinetics and side effect profile is studied. And then we try them for relapsed refractory disease in children. And then after further pharmacokinetic studies in children, only then they will be used for frontline therapy. So nivolumab is being used in many, many conditions in adults and in Hodgkin's also in children, but in refractory Hodgkin's. So this checkpoint inhibitor, nivolumab, it targets PD-1 pathway and is approved for certain subset of pediatric patients as well. And we have used it also in Hodgkin's lymphoma, but quite expensive again. So you can see here, this green thing here is an nivolumab. It has been again made in the lab to come and sit on this PD-1 receptor of the T cell, not allowing the tumor PD ligand to come and attach here. And it allows, therefore, the T cell to remain in the on position and destroy the tumor cell. Another is ipilimumab. It uses the cytotoxic CTLA-4 cytotoxic action of T cells on tumor cells. It blocks it. And again, in phase 1, this is still for pediatric, it's still in trials for the sarcomas and certain solid tumors. It is approved for certain melanomas. Melanoma is again a condition where we don't have good therapy. Moving on to the tumor cell vaccine, just like vaccine for viral infections, and like we saw the COVID, we had these peptide and RNA viruses and whole cell vaccines, etc. So also, even for the tumor cells, people have been working for many decades, at least 2 decades on it. They'll take the tumor cell, kill them by either irradiation or some other mechanism, extract DNA or peptide or RNA, modify it, inject it into the patient, and try to produce antibodies against it, and also stimulate the T lymphocytes. But somehow this hasn't worked very well for children, and the only successful disease is the prostate cancer, the castration-resistant prostate cancer, where this Splt immunotherapy works. So it targets the prostatic acid phosphatase found in 95% of prostate cancers. So, but in children, we still don't have successful vaccine. But I may tell you, I think I deleted one slide over here, that the tumor vaccine, cancer vaccines, there are 2 other successful vaccines, which are hepatitis B vaccine and the HPV vaccine. The hepatitis B vaccine, as we know, we give it to all children. It protects us against hepatitis B. And as we know, chronic hepatitis B predisposes to liver cancer, hepatocellular cancer. And HPV, the Gardasil, or that we well know, protects one against the cervical cancer, certain genital cancers, and even in certain head and neck cancers where the HPV virus is endemic or is colonized for many years. So these are 2. So this process, the preventing viral infections that cause cancer is successful, but that is like a benefit of it. And this tumor cell vaccine is still in the lab. We still don't have a successful vaccine for children. So to conclude, there is dramatic progress in our understanding of genomics, cancer biology, and immunology, and is fueling exciting new treatments for children. Immunotherapy exploits our body's own immune system to fight cancer cells, which may be by means of antibodies, T cell pathways, cellular therapies, and vaccines. It has given a ray of hope to otherwise certain incurable cancers in children. It can also help us to reduce the toxicity of chemotherapy. One important rider is that we need to know what is a biomarker or antigen present on the cancer, because these are specific or very targeted. And they are clearly more effective than current treatments for the refractory disease, and they are less toxic than the targeted therapies, although they have their own profile of side effects. Currently, cost and availability are major concerns. So I would like to share this last slide with you. On the 14th of February, we did a webinar with our childhood cancer survivors who have given us this a newsletter, and in which they have carried these very strong messages of I had cancer, but cancer never had me. These are all survivors. And being this week of childhood cancer awareness, I want to still remind all of our audience that childhood cancer is curable and we must advocate for them. So thank you very much for providing me with this platform to share my talk. This is just our celebration of survivorship, which we do every 2 years to bring our survivors together and give them support for their future good health as well as for social network. Thank you.
Thank you, madam. Sir, Dr. Choudhary.
I convey my thanks, Dr. Gauri. It was a wonderful talk. And I think the message what you have conveyed are very clear that today the childhood cancers are curable. And at least two things, that hepatocellular carcinoma and the carcinomas occurring following herpes virus with vaccines can be preventable. I think at least these two vaccines, if they are all pediatricians practice and give regularly, certainly can prevent. And you have literally gone for how does these immunotherapy work right from the basic to the current therapies. Of course, these are the challenges, the cost factor and non-availability. But certainly we are moving forward, and maybe in the next couple of years, all these things will be available and will be able to offer cure to these children and improve the results further. And I think that cancer will be winnable, and it is a question of time when we'll be able to cure every child with cancer. And I think with these words, thank you very much. And I'm sure you will be too happy to answer the questions. And Dr. Bimal, you have on a chat box questions have come up.
So, madam presented so well, there is no question in chat box.
Ma'am, the talk was so good that it gave us a real understanding of what medicines are being given to the children. Otherwise, it was always Greek and Latin to, I think, even all of us. So it was really wonderful talk, ma'am, and really opened our eyes to our, what we are actually doing for our patients. When we said
if we have 2 minutes, I just want to highlight one or two other things. Can I have another minute or two?
Yes, of course.
Dr. Gauri, would you
sir.
like to tell us what all immunotherapy drugs you have used, in particular your group of children, and how they have helped us in improving the cures?
So we are using, not only us, but pediatric oncologists and hematologists all over the country. We are using rituximab for non-Hodgkin's lymphoma, high grade.
Yeah.
We are routinely using, and actually the number of cycles of chemo have also been reduced as per international guidelines. Then there is brentuximab.
Yeah.
This is for relapsed or refractory Hodgkin lymphoma. This drug, many of us, and nivolumab. These two we are using for relapsed Hodgkin's. I will not say routinely because nivolumab is available in India, but brentuximab needs to be imported. And there are many companies and many agents who provide the drug within 2 or 3 days to us, but they are both very expensive. So maybe not even 1% of our patient can afford. In some places it may be more, but they are very effective. Brentuximab is now standard of care for adult Hodgkin lymphoma in the USA.
Madam, what's the price?
So I will tell you about nivolumab. One dose or one cycle cost 1 lakh rupees. And it is very cheap compared to brentuximab. I don't remember the current price because it keeps on changing every month. But it is a few lakhs for one cycle. And many cycles have to be given. Maybe 5, 6 or even more. Then other drug is this Ozo anti-CD20 and that BITE or blinatumomab. Again, the cost is in lakhs. So blinatumomab I have just used for 2 patients. It is too expensive, but it is a fantastic drug. Yes, sir.
No, I know. I mean, what I was saying is, except rituximab, which is being used very widely for the treatment of lymphomas, and of course there are benign other many conditions in which the rituximab is being used. whereas the others are yet to be that, made a cost come so down, and they will be used more often in the treatment for cancers. And similarly, CAR T cells, still nobody, I think, has started doing in India. So these are the future therapies which are going to turn the events in our favor. Absolutely. And offer much better results, Yeah, you wanted to speak for 2 minutes on something.
Yes. Since we have an audience of pediatricians, so I just want to highlight one or two things about our childhood cancers. That just on, I think it was on 15th itself, with Delhi IAP, we had a digital meeting. They had told us that on 15th of February, it is International Childhood Cancer Day. So why don't you do a scientific session for us? So we were very excited, and we had two talks in that. One was on early diagnosis of childhood cancer, and other was how to monitor children after completion of therapy. That means how to monitor or surveillance of childhood cancer survivors. And what I just want to highlight is these are two areas where pediatrician has like a critically important role, because childhood cancer is not curable in every case, which comes with advanced disease and in very poor nutritional status because of the cancer. But early diagnosis has excellent cure rates. And early diagnosis is only possible by the physician, by the pediatrician, because children are coming to you for small ailments, and childhood cancer symptoms, they are mimicked, they are mimicry, they are mimics. Prolonged fever, neck nodes, abdominal distension, some petechiae, some bruising, white reflex in the eye, some swelling somewhere in the leg, some bone pains. There is nothing unique about childhood cancer. The only unique thing is these are persistent symptoms, and they are unexplained and do not respond to standard treatment. So we can have a high index of suspicion, or you can just pick up a phone and call us. Hey, these symptoms are there, and the routine CBC can give you a clue for leukemia. So one is this. So early diagnosis, pediatrician has very important role. Without pediatrician, cancer treatment is not possible, because unless you diagnose, we cannot treat. The second is, after the treatment is over, many of the survivors are well for initial few years, but in their 30s, 40s, 50s, as they grow old, they, with aging, develop many problems, chronic health problems, which occur early. And these can be caught in the early teenage phase as well, when they are still under the care of the pediatrician. So because these occur late, once the treatment is over, many of the childhood cancer survivors will disappear into their own village, and they want to forget about it. But they will remain in touch with the pediatrician, because they have got all their initial vaccination with them, and they have grown up in front of them. So they will remain with the pediatrician in the community. So we try to give them a summary card in which we tell what to monitor. So if the pediatrician can just be having a little bit of regular once a year, we say only once a year visit, then they can pick up things like endocrinopathies. They can pick up things like, any other organ dysfunction, a growth failure, small things, which if we, thyroid dysfunction, got radiation to the neck, he will get hypothyroid. He got brain radiation, he will get pituitary failure. Small things. You just monitor the growth chart and you can pick it up. So these are the two main messages, Dr. VP Choudhary, if you will agree with me, that there are very critical role of pediatrician in health of our children and as they grow up.
Thank you, Dr. Gauri. But I must say, early diagnosis is always a key for the cure for the cancer. I think that message, and we need to emphasize, I think I will rather request the branch to have another talk on early diagnosis of cancers in children, because once, there is a saying, eye sees what mind knows. And these CMEs certainly stimulate the minds. And if one knows what are the early symptoms, how to look and have a high index of suspicion, make an early diagnosis rather than delaying it, and send them to the hematologist like you who could handle this patient, make a prompt diagnosis, and initiate the treatment early. I think that is a very crux of it. And many times we know you have been at Rajiv Gandhi, I have been at AIMS. We get children who have been diagnosed, come at stage 3 or stage 4, where the results of treatment are very poor. I think that is the message and crux which should be passed on. And I think our fellow pediatricians are very learned, have to keep an eye open and take care and have an early diagnosis. Maybe I'll request the South Delhi branch, pediatrics, to have another talk on the early diagnosis of cancers.
Right.
With these words, I convey my thanks to Dr. Gauri and Dr. Bimal and Dr. Sandhya for having such a wonderful CMA. Thank you very much.
Thank you, sir.
And
Thank you
over to
the
Bimal. And
session, sir. Thank you so much, sir. Thank you, ma'am, for the wonderful talk. And you know, one more vaccine which I think was being used for cancer, at least in adults, is that BCG.
For bladder cancer.
Bladder cancers, yeah. So that was another vaccine.
Yes, it is for immunotherapy, yeah.
Immunotherapy, yes, yeah.
I think, correct.
There is one question in chat box. Dr. Ayan Sharma, he is asking, can immunotherapy will in future replace chemotherapy?
No.
So it will replace partly the chemotherapy, definitely. It is
but
already
not
replacing.
Total, but not total, you know.
But you never know, sir. They may come with these cars and trucks and whatnot.
As of now, what we stand today.
Today we can't say. But
yeah.
Definitely it reduces the chemotherapy.
Yeah, certainly. You know, if you treat a patient with immunotherapy alone, the results are transient. What we are doing is combining them with the chemotherapy, having a better result, and trying to reduce the cytotoxicity to the various chemotherapeutic drugs, because the number of cycle and the dose what is needed otherwise is being reduced. And therefore, but let us say a decade later, maybe we may be talking of only immunotherapy as the only first line of therapy for cancer treatment. But as of now, not at the moment.
What about the bone marrow bone marrow replacement, which we do for all the leukemias? So you're only talking about immunotherapy for refractory patients, is it?
No, you know the bone marrow. Okay, let Dr. Gauri speak.
So bone marrow transplant are two main types, autologous and allogenic. So the true transplant is an allogenic transplant where the donor is not the self. If the donor is self, it is called autologous. And if it is someone else, it is called allogenic. It is now reserved for things like bone marrow failure. For example, severe aplastic anemia. It is for relapsed leukemias and lymphomas. It is also for things like thalassemia major. It is the only curative treatment for thalassemia major. Then other storage disorders, severe storage disorders, where the disease is in the marrow. So if I may say, it is the only form of stem cell therapy which is successful across the board. Means people, have tried for nerve sheaths and Alzheimer's and rheumatoid arthritis. They have tried stem cell therapy, but it is still purely experimental. So if a disease is in the marrow, we give ablative chemotherapy. That means you give chemo so the marrow is finished off. It is ablated. And then you create an immunosuppressive environment by giving some drugs to allow the donor cells to come and seed into the host marrow and make cells again, but not get rejected. So for that, we give immunosuppressive therapy for about 3 to 6 months, and gradually the body adjusts and we are done. That is transplant. That is also an immunotherapy, because now people are trying to do less toxic chemotherapy for the transplant and modify the cells we give, remove the T cells, keep only the NK cells so that the GVHD won't happen. So yes, people are working, doing a lot of exciting research even in the transplant area.
Yeah, of course, a lot of immunotherapy and conditioning regimens are being changed, modified to improve, to have a better results. And of course, for autologous, you use for patients with the prostate cancer and various other multiple myeloma.
Neuroblastoma, relapsed lymphoma.
So this is what I am saying, even autologous is being used because allogenic is not available every time. And so, today for bone thalassemia, even haplotransplants are being done. So anyway, the BMT itself is a big, huge topic and which can be discussed for hours, Anyway, thank you very much, Dr. Gauri and Dr. I think the South Delhi IAP may like to make some comments. Hand over to them,
Can I ask a question?
Yes, Dr. Choudhary.
Ma'am,
Dr. Praveen Khandu.
Ma'am, excellent talk. It's been ages that have heard somebody like this. Wonderful, excellent. Ma'am, how about this cord blood? आजकल जो बहुत myth चल रहा है उसको store करने का.
We will have a separate talk on that.
Yeah, so it's a hype. It's hype. It is not hope, really. If I may just briefly give the answer. So what does American Academy of Pediatrics? They say that, so cord blood is when the baby is born and you cut the cord, then in the cord from the placenta, whatever 40 ml blood comes or 20 ml comes, it is very rich in stem cells. You could preserve it, but you have to be careful not to infect it with all the E. coli and other bacteria. And it can be used for bone marrow transplant. However, just like we have HLA typing that requires to be done. If it is not HLA match, it won't work. So it has to be HLA match. Then the cell dose is too small to be successful, right? So even if the child is, so it is believed that just like you donate blood, if you really want to collect stem cells of the baby at the time of birth, please donate them to a registry so that anybody who needs them can use them. But if you think that it is your insurance for future, that is a myth. It is a myth because if after 5 years, this child gets some cancer, or at 8 months age, you came to know baby had thalassemia, the same abnormality is there even in the stem cells. But if in your family, there is another child who has a disease for which you need an HLA match sibling donor, like thalassemia major. So if that, us baby ka agar bhai ya behan hai, who requires transplant, then those stem cells might be useful, because if they are HLA matched, then they can be used for transplant. But for
at a certain
no.
At a certain age, when the child is grown and we go for it, don't you think that amount is too less to be?
Too less.
Okay, too less. Can I elaborate little further? You see what you're talking, the cord stem cells. With the good techniques, now they are able to collect 80 to 100 ml of a cord blood. There are two types. One is a public cord blood banking. I think that you say, let me little elaborate. Other is a private. Private means the hype what was created by the community that your child may develop cancer and may require your stem cell. Now the child's stem cells are being preserved with the hope that tomorrow if a child gets a disease and which can be treated by a transplant, the stem cell transplant, and his stem cell cells are lying which can be used. The possibility statistically is 1 in a million where the child will develop the disease and will require a bone marrow transplant. Secondly, Whether those cells will be alive after 20, 30 years if a child person develops a cancer. So that is a hype which was created, and people made for a personal use, what we say that cord stem cells are being used. There it is not of much use, but if one is using for a public, that anybody can use it. It is not for my child, not for my family, but for anybody in the world or in the country, then of course the HLA typing has to be done, the data has to be computerized, stored, and whosoever requires good cord blood stem cell can be combined. And in fact, one is less, then you can combine 2-3 cord stem cells and do a transplant. That is the only when it is a public, but by and large, the public has cord blood collection have not picked up. It is more of a hype. It is not really one which is very effective. And we don't recommend by and large. Nobody, scientific bodies do not recommend. But of course, there are private agencies in India, all over the world, which are trying to collect the cord blood stem cell with the hype that maybe your stem cells of your baby may be useful and save his life in future. That is the... Am I clear? Making it little more? Hello?
Yes, very clear,
Dr.
sir.
Choudhary is saying public cord blood banking is non-existent in India.
In India, private public one, which is run by the government.
So government का है नहीं, private
Yeah.
ही है और private में hype है and we
Yeah.
Yes. There's one more question, I think, in the chat box. Is immunotherapy being used only for relapsed patients or not? Yeah,
Dr. Gauri?
Madam, you are not audible. Madam, you are not audible. Although you
cannot hear you, ma'am. Cannot hear you.
Now you are.
क्या आप बोल दीजिए?
Is immunotherapy only being used for relapsed patients?
Rituximab, can you hear me?
Yes.
Yeah.
So rituximab जो है, rituximab frontline therapy for high-grade B-NHL. All high-grade B-NHL, rituximab monoclonal immunotherapy is standard of care across the country. इसके अलावा और कोई भी नहीं है बच्चों में. The others are all for relapse. Brintuximab, all those others.
Okay.
Blinatumomab, all of those are.
मैम जाते जाते एक बात बता दीजिए प्लीज.
क्या पूछ रहे हैं?
गौरी मैम से. मैम ये मालती मामी भी आप ही हैं?
एक्चुअली वो ना कभी कभी मेरी मदर जो है ना वो यूज करती हैं. वो मेरी मदर का नाम है. वो कभी कभी मेरा कंप्यूटर